In the UK and the US, atrial fibrillation contributes to around 1 in 5 strokes. And the worst part is, many people don't feel it at all. No palpitations, no breathlessness, no warning signs whatsoever. The first symptom could be the stroke itself. And I've seen this play out in the emergency department many times. Someone walks in or even gets rushed in by ambulance with sudden weakness down one side of their body, with slurred speech or facial droop, or even worse, unconsciousness. We run the tests and we find the stroke, and then we look for the cause. And there it is on the ECG, atrial fibrillation, or AF, or AFib if you're in America. Sometimes the patient knew they had it, sometimes they had no idea. But either way, what's happened is this. Their heart has been quietly building a clot, and that clot has broken off and travelled straight to the brain, blocking an artery and cutting off blood flow to a section of brain tissue. The damage can be catastrophic, and in many cases, it's irreversible. I'm Dr. Alex, and over the last 10 years working in the emergency department, I've become quite obsessed with understanding the patterns behind preventable disease. Atrial fibrillation and stroke is one of those areas where the numbers are staggering, but the understanding among the public is often quite poor. So I want to give you the insights I've picked up over the years, explaining exactly what atrial fibrillation is, why it causes strokes, how to recognise it, and what you can actually do about it. And all I ask in return is that by the end of the video, if you've learned something new or useful, then please consider subscribing to the channel. It really does mean so much. So, when people hear irregular heartbeat, they think about symptoms. They think about palpitations, they think about their heart racing or skipping beats, or maybe they've got an Apple Watch that's flagged something unusual. But here's the reframe that I want you to understand from the start. Atrial fibrillation, or AF, isn't primarily scary because your pulse is irregular. It's scary because it can quietly turn part of your heart into a clot factory, and then fire that clot straight at your brain. That's the real danger. The irregular rhythm itself is just the surface problem. Underneath, there's a much more sinister process that's happening regarding blood flow, stagnation, and clot formation. And that's what we need to understand. So let's start with the basics, because understanding how AF works makes the stroke risk completely intuitive. In a normal heart, you've got a natural pacemaker called the sinoatrial node sitting in the right atrium. This fires off electrical signals in a nice, organised rhythm. Those signals spread across both atria, the upper chambers of the heart, causing them to contract and squeeze blood down into the ventricles, the lower two chambers. Then the ventricles contract and pump blood out to the lungs and the rest of the body. It's coordinated, it's efficient, and blood flows smoothly through every chamber. In atrial fibrillation, that organised system breaks down. Instead of one pacemaker sending out clean signals, you get multiple chaotic electrical wavelets firing off all over the atria. The atria don't contract properly anymore. Instead, they quiver, they fibrillate, and when they're quivering instead of squeezing, they're not pushing blood effectively into the ventricles below. The electrical signals are also reaching the atrioventricular node, the gateway between the atria and the ventricles, in a completely disorganized way. So the ventricles start beating irregularly too. That's why when you check someone's pulse in AF, it's described as irregularly irregular. There's no pattern to it. One beat comes quickly, the next one takes ages, and then another quick one. It's chaotic. Now, modern guidelines on AF management emphasize that this isn't just about controlling the rhythm or the rate. The focus has shifted significantly towards stroke prevention and towards managing the underlying risk factors and comorbidities that come along with AF. Because AF rarely exists in isolation, it's usually part of a bigger picture involving blood pressure, involving weight, diabetes, sleep apnea, alcohol intake, and many more. But before we get into any of that, we need to understand the clot problem a bit better, because that's the bit that causes the strokes. This is the crucial section, and it's where everything starts to make sense. When the atria are fibrillating and not contracting properly, blood flow inside them becomes sluggish. Blood is meant to keep moving. When it slows down or pools, that creates the perfect environment for clots to form. There's a concept in medicine called Virchow's triad, which describes the three conditions that promote clot formation. Let me just translate that into plain English. First, you've got stasis. That means blood isn't flowing properly. It's sitting still or moving very slowly. In atrial fibrillation, because the atria aren't squeezing, blood pools in the chambers. Imagine a river that suddenly slows down into a trickle. Sediment starts to settle. Well, it's the same principle. The second thing you've got is endothelial dysfunction. The endothelium is the inner lining of your blood vessels and heart chambers. In AF, this lining becomes more prothrombotic. That means it's more likely to trigger clotting. The surface that the blood is touching is no longer as smooth or clot resistant as it should be. The third one is that there's a state of hypercoagulability and inflammation. People with AF often have systemic changes in their blood chemistry that makes clotting more likely. Their blood is, in a sense, primed to clot. So you've got three ingredients coming together: slow-moving blood, a sticky surface, and blood that's ready to clot. If you put those together, and you've got a recipe for thrombus formation. Now, there's one specific area of the heart where this becomes particularly dangerous. It's called the left atrial appendage. This is a small pouch that sticks out from the left atrium. In non-valvular atrial fibrillation, which is the most common type, the left atrial appendage is where the majority of embolic clots originate. Think of it like a cul-de-sac off the main road. If traffic stops flowing properly, then debris accumulates in the dead end. Blood can sit in this appendage, it can stagnate and form a clot. And once that clot is there, it's only a matter of time before something dislodges it. So when a clot forms in the left atrium or the left atrial appendage, it doesn't necessarily cause problems straight away. The danger comes when it breaks free. Once it embolizes, it then enters the bloodstream and starts traveling. The left atrium connects to the left ventricle, which then pumps blood out into the aorta and up towards the brain via the carotid arteries. So that clot, if it's the right size, can travel up through the carotid circulation and lodge into one of the cerebral arteries. And the moment it blocks that artery, blood flow to a section of the brain stops. That's an ischemic stroke. So let's talk about what happens in the brain when blood flow stops, because this is where the irreversible brain damage occurs. Your brain is an incredibly energy-hungry organ. It makes up about 2% of your body weight, but it uses roughly 20% of your oxygen and glucose. Neurons, which are the cells that do all of the thinking and the signaling, rely on a constant supply of ATP, which is the energy currency of the cell. They generate ATP through aerobic metabolism, which requires oxygen and glucose. When blood flow stops, within seconds to minutes, neurons start losing their oxygen and glucose supply. ATP production crashes, and when ATP runs out, the pumps that maintain the cell's internal environment start to fail. Sodium floods into the cell, potassium leaks out, and calcium rushes in. This triggers a cascade of events called excitotoxicity. Glutamate, which is a neurotransmitter, gets released in excessive amounts and overstimulates neighbouring neurons. The influx of calcium activates enzymes that start breaking down cell structures. The core area where blood flow is completely cut off forms an infarct very quickly. That tissue is now dead. But around that core, there's an area called the penumbra, where blood flow is reduced but not completely absent. The penumbra is salvageable, but only if blood flow is restored quickly. That's why in stroke medicine, the phrase is time is brain. Every minute counts. Now, here's something important about strokes caused by atrial fibrillation. They tend to be more severe than strokes caused by other mechanisms. Cardioembolic clots, the ones that come from the heart, can be larger than clots formed in the blood vessels. They're more likely to cause large vessel occlusions, blocking major arteries and causing more extensive brain damage. The outcomes are often worse, the disability rates are higher, and the mortality is higher as well. So when we talk about preventing strokes in AF, we're talking about preventing some of the most devastating strokes that exist. One of the big challenges with atrial fibrillation is that it doesn't always announce itself. Some people do get symptoms. They feel palpitations, a sensation that the heart is racing or fluttering. They might feel breathless, especially with exertion. They might notice fatigue, reduced exercise tolerance, dizziness, or even some chest discomfort. But plenty of people feel absolutely nothing. And that's the problem. We can't rely on symptoms to detect AF, because absence of symptoms doesn't mean absence of risk. There are a couple of ways that AF gets picked up. The first is just through a simple pulse check. If you or someone else checks your pulse and finds that it's quite irregular, especially if it's new, then that's a red flag. It warrants an urgent ECG. And the ECG is the gold standard for diagnosing atrial fibrillation. It shows the characteristic pattern: no clear P waves, an irregular rhythm, and a chaotic baseline. Now, wearable devices like smartwatches are also picking up more and more cases these days. They can flag irregular rhythms and prompt people to get checked out. They're useful as a screening tool, but they're not a diagnosis. You really do still need an ECG to confirm it. And that's important because not every irregular rhythm is atrial fibrillation, and not every irregular reading on a smartwatch is accurate. There are certain people who should be extra alert to the possibility of AF. Aging is a big risk factor. The prevalence of AF increases substantially with age. Hypertension is another major driver. Sleep apnea is also increasingly recognised as a contributor. Obesity, diabetes, excess alcohol intake, thyroid disease, and any form of structural heart disease all increase the likelihood. Atrial fibrillation is tightly linked to your overall comorbidity burden. It rarely exists on its own, and this is something that the latest European guidelines on AF really emphasises. Managing AF isn't just about managing the heart rhythm, it's about managing the whole person and all their cardiovascular risk factors. So at this point, let's just be very clear about the stakes. Atrial fibrillation substantially increases your risk of ischemic strokes. It's a major public health burden, and the thing is, just controlling the heart rate isn't enough if your stroke risk is high. You can slow the heart down, you can make someone feel better, but if you don't address the clotting risk, then the danger remains. That clot can still form, and it can still fire off to the brain. The decision about who needs treatment to prevent strokes is based on risk assessment. In clinical practice, we use tools like the CHAD-VAS score to estimate stroke risk based on factors like age, sex, whether you've got heart failure, hypertension, diabetes, whether you've had a prior stroke, and vascular disease. If your risk is high enough, then the guidelines recommend anticoagulation, blood thinning medication, to reduce the chance of clot formation. And this includes medications like warfarin, apixaban, or rivaroxaban. This has to be balanced against bleeding risk because anticoagulants do increase the risk of bleeding. But for many people, the stroke risk far outweighs the bleeding risk, and anticoagulants is the right choice. It's worth noting that aspirin, which used to be used quite commonly, is generally not sufficient for stroke prevention in AF when anticoagulation is indicated. This is a nuanced area, and the decision needs to be made with your doctor based on your individual circumstances. But here's what I want you to take away. If atrial fibrillation is left unrecognised or untreated, the consequences can be catastrophic. Strokes don't give warnings, they give consequences, and in many cases those consequences are permanent disability or death. So what should you do next? Well, if you suspect that you might have atrial fibrillation, or if you've been picking up irregular rhythms on a smartwatch, here's what you need to do. The first thing is check your pulse properly. Feel for that irregular pattern, or take note of what your device is telling you. The second thing is arrange an ECG. If you're feeling unwell, symptomatic, or if this is a new finding, that needs to happen urgently, ideally on the same day, so please feel free to go to A&E. Do not wait weeks for a routine appointment. The third thing is, if AF is confirmed, the critical question to ask your doctor is, what's my stroke risk and do I need an anticoagulant? This conversation is absolutely essential. It's not automatic that everyone with AF needs anticoagulation, but it's a decision that needs to be made based on a proper risk assessment. And the fourth one is address the drivers. Get your blood pressure under control. If you've got sleep apnea, then get it treated. Lose weight if that's relevant to you. Cut down on alcohol, improve your fitness, get your diabetes managed. These aren't optional extras. These are core parts of reducing your risk of recurrence and progression. The newer guidance on AF really hammers this home. It's not just about the rhythm, it's about the whole metabolic and cardiovascular picture. So let me just bust a few myths before we finish the video. The first myth is I'm fit, so I can't get AF. Well, that's not true. Endurance athletes, people who are very fit, can absolutely develop AF. It's not just about fitness. Myth number 2 is if I don't feel palpitations, then I'm safe. Well, this absolutely isn't true. Silent AF is real and it carries the same stroke risk. Myth number 3 is that aspirin is enough to prevent strokes in AF. Well, this generally isn't the case when anticoagulation is indicated. This needs careful discussion with your doctor. One more thing here. If you or someone around you develops sudden neurological symptoms like sudden weakness or speech disturbance, facial droop, vision loss, sudden collapse, or just a bit of sudden confusion, then treat that as an emergency. The FAST acronym, which is face, arms, speech, and time, is really useful. But AF-related strokes can present in many ways. Anything sudden and neurological is an emergency, so call 999 or 911. And so I really hope you got something from this video. If you did, then please subscribe to the channel. It means so much, and hopefully we can get this video to reach as many people as possible. Thank you so much, and I will see you in the next video.